If you're over 60 and your doctor just celebrated getting your blood sugar down to normal, you need to stop and hear this. A clinical analysis reviewed by the American Geriatrics Society tracked thousands of older adults who hit textbook perfect blood sugar levels. What they found should have changed how every doctor in the country treats patients over 60. The seniors with so-called ideal blood sugar had significantly higher rates of catastrophic falls, accelerating memory loss, and in some cases, a measurably higher risk of dying, not from high blood sugar, from the treatment designed to control it. Here's what makes this dangerous. Nobody told them. Their numbers looked perfect. Their doctor was pleased, and their brain was quietly starving. Here's what the numbers actually show. A study tracked 1,162 older adults with diabetes over 13 years. Among those whose blood sugar was pushed too low, falls occurred at a rate of 8.81 per 100 person years. Among those it wasn't, just 2.17, more than 4 times higher after adjusting for age, medications, kidney function, and cognitive scores. That's not the worst of it. A separate analysis of over 21,000 older adults found that even one hypoglycemic episode nearly doubled the odds of a fall-related event in the following 12 months. Adjusted odds ratio, 1.95, not from high blood sugar, from low blood sugar, the kind your doctor is actively trying to achieve. And the brain damage? A study out of Barcelona evaluated elderly patients after severe hypoglycemic episodes and found profound deficits in memory, speech, and executive function. 4 or more severe episodes within 12 months tripled the risk of cognitive impairment, not doubled, tripled. This is not fringe research. These findings are cited in the guidelines of the American Geriatrics Society, the American College of Physicians, and the American Diabetes Association. The research exists. The guidelines have changed, but in the average doctor's office, a 72-year-old is still being handed targets designed for a 40-year-old. And that gap is costing people their independence, their memory, and sometimes their lives. In the next 15 minutes, I'm going to show you 3 things your doctor almost certainly hasn't told you. 1. The exact blood sugar range now linked to the longest survival, sharpest thinking, and fewest falls in adults over 60. And why it's higher than what your lab report calls normal. 2. The silent mechanism happening inside your brain right now if your blood sugar is being pushed too low. Why you may feel nothing before a fall, nothing before a mental blackout. 3. A simple to-step home test using a basic glucose monitor that tells you tonight whether your current target is putting you at risk, and the exact numbers to bring to your doctor. I'm Dr. Cephas, sat across from older adults doing everything right, taking their medications, hitting their numbers, following every instruction, and still ending up in the emergency room with a fractured hip, still sitting in a neurologist's office being evaluated for early dementia. Too many of those conversations didn't have to happen. The research I'm walking you through today is not experimental, not controversial. It is published, peer-reviewed, and cited by the most respected medical institutions in this country. What is controversial is how slowly it has moved from journals into actual doctors' offices and how many older adults are being harmed in that gap. If you are over 60 or you love someone who is, this could be the difference between a decade of sharp thinking and physical independence and a cascade of falls and cognitive decline that begins with a blood sugar target that was never designed for your body. That is not a small thing. Before we go further, do one thing. Right now, drop your age in the comments, just the number. Nothing else. Everything I'm about to share, the target ranges, the risk thresholds, the specific numbers, applies differently depending on whether you're 62, 72, or 82. I'll be referring back to those age brackets throughout, so your comment will actually help you follow along. And if any of these sound familiar: mental fog an hour after eating, unexpected dizziness when you stand up, a wave of exhaustion mid-afternoon, a near miss where you grabbed a wall to steady yourself, add the word foggy to your comment. Because in about 4 minutes, I'm going to explain exactly what is happening inside your brain during those moments. And when you hear it, you'll understand these are not just signs of aging. They are a signal, with a specific, correctable cause. Drop your age now. Add foggy if that hit close to home. Then let's get into this. Here's what's happening in doctors' offices across the country right now. There's a good chance some version of this has already happened to you. A 71-year-old woman comes in for her routine checkup, fasting blood sugar, 112, A1C 6.3%. Her doctor sees that 112 is above the 99 mg or DL cutoff, reaches for the prescription pad, and tells her to cut carbs and aim for tighter control. 3 months later, fasting glucose, 94, A1C 5.9%. Doctor is pleased. Numbers are perfect. Everyone in that room believes this is a success story. Here's what the lab report doesn't show. 2 weeks after her medication increased, she started waking at 3 a.m. with her heart pounding. She assumed anxiety. A few days later, she's making breakfast and the room tilts. She grabs the counter, doesn't tell her doctor, assumes it's just age. Then one Tuesday morning, she gets up from the couch to answer the phone. Her brain running on a fasting glucose of 91, textbook perfect by every standard chart, doesn't have enough fuel to coordinate the shift from sitting to standing. Her vision dims. Her right leg doesn't respond. She goes down hard against the corner of the coffee table. Now we're not talking about blood sugar numbers. We're talking about a fractured wrist, a 6-week recovery, a daughter driving 3 hours every weekend because her mother can no longer be trusted to live alone. This is the beginning of lost independence, and it didn't start with high blood sugar. It started with a fasting glucose of 91 that every chart in every clinic would stamp with the word normal. This plays out thousands of times every single day, and it is preventable. So if this research exists, published, cited, endorsed by the most respected institutions in medicine, why hasn't your doctor mentioned it? 3 reasons. First, the guidelines were built on the wrong population. The landmark trials that set fasting blood sugar below 100 and A1C below 5.7% as gold standard targets were conducted primarily on younger, newly diagnosed patients. When the results came in, the guidelines were applied broadly, across all ages, across all health statuses. The assumption was simple: what protected a 45-year-old must also protect a 75-year-old. That assumption was never tested. It was inherited. Second, the correction travels slowly. Over the past decade, researchers studied older populations specifically, and what they found directly contradicted the universal model. The Accord trial, the Advance trial, the VADT trial, all of them showed that intensive glucose control in older, more complex patients did not reduce cardiovascular events or mortality. In some cases, it increased risk. The guidelines have started to update, but it takes years for new research to reach clinical guidelines and even longer for those guidelines to change what happens in a 15-minute appointment. Third, and this is the hardest one to say out loud, for decades, doctors have been trained with one non-negotiable message: lower blood sugar saves lives. That message is built into every medical school curriculum, every clinical protocol, every performance scorecard that hospitals use to evaluate physicians, shifting from that to, for this patient, at this age, a moderately higher blood sugar is actually safer requires individualized thinking that our healthcare system does not make easy. It requires time, it requires nuance, and it requires pushing back against a metric that still follows doctors throughout their careers. The research has moved, the guidelines have started to move, but the average doctor's office is still catching up, and in that gap older adults are falling, losing cognitive function, and losing independence. Here's what's going to sound counterintuitive. Stay with me because this is where everything changes. For a 40-year-old, lower blood sugar equals better outcomes. The evidence is solid, but something fundamental shifts after 60. Not a small shift, a biological reorganization that changes what blood sugar numbers actually mean for your brain, your balance, and your survival. 3 critical changes. Each one demands a completely different target. Change 1: your brain's fuel supply. Your brain is 2% of your body mass. It consumes 20% of your entire glucose supply. And unlike your muscles or liver, it has virtually no ability to store glucose as backup. It depends on continuous, uninterrupted fuel delivery right now, every second you're awake. In a younger brain, that system has generous tolerance. But research shows that inside the aging brain's actual tissue, available glucose runs between just 1.0 and 2.5 millimoles per liter, an extraordinarily narrow margin. When systemic blood sugar is pushed to the low end of normal, the aging brain can slip below its personal threshold, not into what a lab flags as dangerous, just into the lower range of normal, and that triggers neuroglycopenius cerebral fuel starvation. The brain fog an hour after lunch, the word that disappears mid-sentence, the room that tilts when you stand up too fast. These are not random symptoms of aging. They are your brain telling you it is running on insufficient fuel. Think of it this way. A phone battery at 20% gives a new phone 2 more hours on a 3-year-old. Phone with a degraded battery 20% might mean 20 minutes, and it shuts down without warning. The number looks the same. The reality is completely different. Change to your body's early warning system. In a younger adult, when blood sugar drops, the body triggers a precise alarm. Heart rate rises. A mild sweat appears. Shakiness, hunger. These warning signs say, eat something now, before this becomes a crisis. After 60, that alarm system becomes profoundly unreliable. The threshold at which physical warning signs trigger shifts downward. The body waits longer before sounding the alarm. At the same time, the threshold at which cognitive impairment begins shifts upward. The brain starts malfunctioning at a higher blood sugar level than before. The result is a dangerous convergence researchers call hypoglycemia unawareness. The brain begins to fail before the body sends a warning. In one experimental study, glucose was held at critically low levels in both older and middle-aged diabetic patients. The middle-aged group showed a pronounced surge in warning symptoms. The older group showed almost none. Only 1 out of 13 older adults correctly identified that their blood sugar had dropped to a dangerous level. And both groups showed profound slowing of reaction times that persisted for a full 30 minutes after glucose was restored to normal. The brain lags far behind even after the numbers recover. This means an older adult can be cognitively impaired, confused, slow, spatially disoriented while their blood sugar reads perfectly normal, and they won't feel it coming. Change 3. Your body's ability to process glucose at all. After 60, the body undergoes sarcopenia, progressive loss of skeletal muscle mass. This matters because skeletal muscle is the primary site where insulin drives glucose out of the bloodstream and into storage. Less muscle means less capacity to clear glucose efficiently. At the same time, the aging pancreas produces insulin more slowly after a meal. Glucose rises higher, stays elevated longer, and when that delayed insulin response finally peaks, it overshoots, causing a rapid drop hours after the meal that hits an already fragile system. For older women, estrogen decline after menopause directly destabilizes insulin response, creating glycemic swings that are wider and faster than anything the younger body experiences. 3 changes. Together they create a body that is exquisitely vulnerable to the low end of normal, not to dangerously low blood sugar, to the lower range of what every standard chart calls perfectly fine. When a doctor drives an older adult's blood sugar as low as possible without accounting for these shifts, they are not preventing harm, they are creating it. Now let me show you exactly what the research found, because the specifics matter. These are not trends or theories. These are measured outcomes in real older adults tracked over years, adjusted for every confounding variable researchers could identify. The ARIC study followed 1,162 older adults with diabetes over 13 years. Real-world patients, real-world complexity. 3 separate layers of statistical adjustment controlling for age, sex, medications, kidney function, cognitive scores, body mass index, depression, and a full comorbidity index. Here's what they found. No severe hypoglycemia falls at 2.17 per 100 person years. Severe hypoglycemia 8.81, more than 4 times higher. Even after all 3 rounds of adjustment, severe hypoglycemia carried a hazard ratio of 2.23 for any traumatic fall and 2.27 for falls serious enough to require hospitalization. More than twice the risk after accounting for everything else. A separate matched cohort analysis compared 21,613 older adults who experienced a hypoglycemic episode against 21,613 who didn't, matched precisely for age, health status, and medication use. Adjusted odds ratio for fall-related events in the following 12 months, 1.95, nearly double, from a single low blood sugar event. Now look at fractures. A Japanese cohort study tracked elderly diabetic patients over time. For older men who experienced one severe hypoglycemic episode, fracture hazard ratio 2.81, multiple episodes 3.46. For older women with multiple episodes 2.25. All figures held after adjusting for age, diabetes duration, body mass index, and baseline bone health. And then there's the mortality data. A retrospective cohort study evaluated older diabetes patients across the full spectrum of blood sugar control. The lowest mortality rates were not in the tightest control group, not in those with the lowest A1C. They were in those with intermediate control and a 1C between 6.0% and 8.0%. Overtreatment pushing a 1C below 6.0% carried a small but statistically significant increased risk of death, comparable, the researchers noted, to the mortality risk seen in the worst controlled diabetes, a 1C above 10%. Read that again. Being overtreated carried a mortality risk comparable to being undertreated. The danger wasn't just at the high end, it was equally present at the low end. The ACCORD trial, the ADVANCE trial, the VAD trial all confirmed it. Intensive glucose control did not reduce cardiovascular events or overall mortality in older populations. In the ACCORD trial, targeting a 1C at or below 7.0% actually increased the risk of premature mortality. The 15-year VAD follow-up found no long-term benefit on cardiovascular outcomes, total mortality, or quality of life. The evidence is not ambiguous, not preliminary, replicated across multiple study designs, multiple populations, multiple decades. For adults over 60, the sweet spot is not the tightest possible control. It is moderate control, and the line between protective and harmful runs directly through the range that standard lab charts still stamp with the word normal. Here's what's shocking. There is a simple protocol less than 4 minutes that can tell you tonight whether your blood sugar management is putting your brain and body at risk. Most doctors aren't doing this routinely. Most patients have never been shown it, and it requires nothing more than a basic glucose monitor available at any pharmacy for around $30. 3 readings, write every number down. Reading 1, fasting morning baseline. Before you eat, drink anything except water, or take any medications. Sit quietly for 5 minutes. Then check your blood sugar, write down the number. According to age-adjusted targets now supported by the American Geriatrics Society, a healthy fasting glucose for an active, independent adult over 60 falls between 80 and 130 mg or DL, not the under 100 cutoff on your lab report. If your number is consistently coming in below 90, that is a signal worth discussing with your doctor, regardless of what the reference range on your printout says. Reading to 2-hour post-meal check. Have your normal breakfast. Set a timer for exactly 2 hours. Check again. Write it down. For adults over 60, a post-meal reading below 160 mg or DL at 2 hours is appropriate by current geriatric guidelines. The standard adult target is below 140, but pushing post-meal glucose. That low in an older adult with reduced muscle mass and delayed insulin response can trigger the exact overshoot drop hours later that causes afternoon brain fog, sudden fatigue, and the dizziness that precedes a fall. Reading 3, the afternoon drop test. This is the one most people never think to check. Set an alarm for 3 to 4 hours after your largest meal, usually lunch. Check your blood sugar at that point. This is the window when the delayed insulin overshoot is most likely to hit. If your reading is below 85 mg or DL, even if you feel relatively fine, your brain may already be operating below its functional threshold. Remember what the research showed. In adults over 60, cognitive impairment begins before the physical warning signs arrive. You may not feel the drop, but your reaction time, your balance, and your spatial awareness are already compromised. What you're looking for: a pattern, not a single number. Fasting consistently below 90, flag it. Post-meal reading lower at 2 hours than 1 hour by more than 30 points, flag it. Afternoon reading consistently below 85, flag it. Do this for 7 consecutive days. 7 days gives you a pattern your doctor cannot dismiss as a single anomaly. It gives you an average. It gives you variability. And it gives you the evidence to walk into that appointment and say, here is what my blood sugar is actually doing across my waking hours, not just when I'm sitting still in your office at 10 a.m. If those readings correlate with the moments you felt foggy, dizzy, or unsteady, that is the conversation you need to be having. And now you have the numbers to have it. So what should your blood sugar actually be? I'm going to give you the ranges that current research and updated clinical guidelines associate with the best outcomes for different age groups. But understand this first, these are starting points. Your personal target must be determined with your doctor based on your complete picture: medications, kidney function, cognitive status, fall history, your own goals. What I'm giving you is the framework the research supports. What your doctor gives you should be the version that fits your specific body. Ages 60–74, generally healthy and functionally independent. Fasting blood glucose, 80–120 mg or dl post-meal target, below 160 mg or dl at 2 hours. For those managing diabetes, NA1C between 7.0% and 7.5% is now considered appropriate by the American Geriatrics Society, not the under 5.7 or under 7.0 targets still printed on most lab reports. This range protects against long-term complications while preserving adequate fuel delivery to the brain and avoiding the dangerous overshoot drops that trigger falls. Ages 75–84, relatively healthy but managing some chronic conditions. The evidence supports relaxing those targets further. Fasting glucose, 90–130 mg or DL-A1C between 7.5% and 8.0%, endorsed by both the American College of Physicians and the American Diabetes Association. Notice that is higher than the younger group. That is not a compromise. That is the correct target, accounting for increased sarcopenia, slower insulin response, narrower brain glucose tolerance, and the significantly elevated risk of hypoglycemia unawareness that research has documented in this age bracket, over 85 or frail. At any age, the American Diabetes Association is explicit. For patients with complex health status, A1C below 8.0%. For patients who are frail, cognitively impaired, or have limited life expectancy, A1C targeting may be inappropriate entirely. The focus shifts to one thing: preventing symptomatic hypoglycemia and avoiding the acute glucose extremes that trigger immediate physical harm. At this stage, quality of life, physical stability, and cognitive preservation take clear priority over theoretical long-term benefits that were never demonstrated in this population to begin with. Same numbers, completely different reality. 2 people, both 74. Both with a fasting glucose of 118 and NA1C of 6.8%. On paper identical, in practice couldn't be more different. The first is independent, mentally sharp, walks 30 minutes daily. Her 6.8% already sits within an appropriate target range for her age. Pushing her below 6.5% carries meaningful hypoglycemia risk with very little evidence of additional benefit. The second is 74 with mild cognitive impairment, 2 falls in the past year, stage 3 kidney disease, and 4 other medications. For him, 6.8% is not a target to tighten. It is a warning sign that his current regimen may already be too aggressive. Research shows older adults with early cognitive impairment frequently miscalculate insulin doses, skip meals without adjusting medications, and fail to recognize their own hypoglycemic symptoms, creating a feedback loop where each low blood sugar episode accelerates the cognitive decline that makes the next episode more likely and more dangerous. For him, the clinical priority is not getting that A1C lower, it is getting it slightly higher to 7.5% or above while simplifying his medication regimen to reduce dangerous lows. The American Geriatrics Society Choosing Wisely campaign is explicit. Avoid using medications to target NA1C below 7.5% in adults over 65. When doing so increases hypoglycemia risk. Same numbers, same age, completely different clinical reality. Treating the number rather than the person behind the number is precisely how older adults end up on the floor at 3 a.m. with a fasting glucose, their lab report stamped with a green check mark. Let me give you 5 concrete steps you can start tonight. Not next week, not after your next appointment, tonight. Because the gap between knowing this and acting on it is exactly where the risk lies. Step 1. Start your 7-day glucose log tonight. If you have a home glucose monitor, use it. If you don't, get one. Any pharmacy, around $30. No prescription needed. Every day for 7 days, 3 readings. Fasting before breakfast. 2 hours after your largest meal, 3 to 4 hours after lunch. Write down the number, the time, the date, and what you ate. You are not collecting a single data point. You are building a pattern your doctor cannot dismiss. Step to perform the afternoon drop assessment. For the next 7 days, pay specific attention to that 3 to 4 hour post-lunch reading. Every time it comes in below 85 mg or DL, write the word drop next to it. You may feel fine, that is the point. In adults over 60, cognitive impairment and balance disruption begin before the physical warning signs arrive. Documenting these readings gives you objective evidence that subjective symptom reporting alone would never capture. Step 3. Connect your symptoms to your log. Every time you experience unexplained mental fog, difficulty finding words, sudden afternoon fatigue, dizziness when standing, or a near miss where you grabbed something to steady yourself, write it down next to the nearest glucose reading. You are looking for correlation. If your foggy afternoons consistently follow your lowest glucose readings, that is not coincidence. That is a physiological pattern with a name, a mechanism, and a solution. And it transforms a vague complaint into a clinical conversation your doctor has to take seriously. Step 4. Schedule a dedicated appointment, not your general checkup, not a visit where you mention this at the end. A dedicated appointment where blood sugar management is the stated reason. Bring your 7-day log, bring your symptom notes, and arrive with specific questions. Ask your doctor, given my age, my functional status, and my complete medication list, what a 1C target is actually appropriate for me according to current geriatric guidelines. Ask whether your regimen includes sulfonylureas like glyburide or complex insulin protocols medications. The American Geriatrics Society now recommends reconsidering in older adults due to elevated hypoglycemia risk. Ask whether your post-meal and afternoon glucose patterns have ever been evaluated, not just your fasting number. Not just your A1C. You are not challenging your doctor. You are arriving as an informed participant in your own care. Any physician worth their license will welcome it. Step 5. Refuse to accept age as the explanation. Brain fog, afternoon fatigue, dizziness when standing, unexplained near falls, disrupted sleep. Do not allow these to be dismissed as simply getting older. They are not inevitable. They are not untreatable. Based on everything the research shows, they may have a direct, measurable, correctable metabolic cause. Many older adults suffer in silence for months, even years, assuming this is just what aging feels like. Their glucose log would tell an entirely different story in 7 days. You have the protocol. You have the numbers. You have the language. The only remaining step is to use them. Let's take a moment to recognize what you now understand. You know that the blood sugar targets on your lab report were established in studies conducted on younger adults and were never validated for a body over 60. You know that forcing an older adult to meet those targets is not neutral. It is an active driver of brain fog, falls, fractures, cognitive decline, and in documented cases, premature mortality. You understand the 3 biological mechanisms: the aging brain's razor-thin glucose margin, the warning system that goes silent before the fall, the metabolic instability that makes the lower end of normal genuinely dangerous. You know what the research shows: the ARIC study, the matched cohort of 21,000, the Accord, Advance, and VADT trials, all pointing to the same conclusion: moderate control, not tight control, is what protects an older adult's brain, balance, and life. You have the age-adjusted targets, the 7-day protocol, the symptom log, the specific questions to bring to your next appointment. Most people your age will leave that appointment with the same targets, the same medications, and the same vague reassurance that their numbers look fine. You will not. If this video gave you clarity, if it answered questions you've been carrying for a long time, drop the word informed in the comments right now. That one word is a commitment to yourself that you're going to start the glucose log, book the appointment, stop accepting age as the explanation for symptoms that have a name, a mechanism, and a solution. I read every single comment and I want to see it. Now share this video with a parent, a spouse, a friend who mentioned feeling foggy, someone who's fallen in the past year and doesn't understand why. The research I walked you through today is sitting in peer-reviewed journals, but it is not sitting in the average conversation between an older adult and their doctor. The only way that changes is if people like you put it there. One share could prevent a fall. One share could preserve someone's independence. And subscribe, because what I'm covering next connects directly to everything we discussed today. The 3 specific foods research identifies as triggering the dangerous afternoon glucose drop in adults over 60. including one that appears on virtually every diabetes-friendly meal plan in circulation and is almost universally recommended as a healthy choice for seniors. The drop that causes the fall doesn't always start with a medication. Sometimes it starts with breakfast. You're going to want to see that disclaimer. This video is for educational purposes only and is not medical advice. Never adjust or discontinue blood sugar medications without consulting your doctor. If you experience symptoms of severe hypoglycemia, confusion, loss of consciousness, or seizure, seek emergency care immediately. The monitoring protocol in this video is intended to generate information for discussion with your healthcare provider, not for self-diagnosis or self-treatment.